Hello, everyone. Thank you for joining today's Cost Measure Field Testing webinar. The purpose of this webinar is to provide information about the field testing of 5 episode-based cost measures before their consideration for potential use in the cost performance category of the MIPS-based merit-based incentive payment system of the Quality Payment Program. I will now turn it over to Ray DeSotos from CMS to start the presentation.
Thanks, Olivia, and hi, everyone. My name is Ray DeSotos, and I'm the MIPS Cost Measure Lead from the Centers for Clinical Standards and Quality at CMS. I will go through the next few slides for our introduction before handing it off to our measure development contractor. And next slide, please. This is just a CMS disclaimer, just noting that the presentation is intended for reference. Yeah, next slide, please. Thank you. So today we'll be providing an overview of the cost measure development process and measure construction, the 5 episode-based cost measures being field tested, the materials and activities that are part of this year's field testing, and finally, we will walk through an example of the field test report. At the end of the presentation, there'll also be an opportunity to ask questions. Next slide, please. These are just a few acronyms that will be in the presentation for your reference. Next slide, please. Okay, so to begin, I'll provide some information about what field testing is and a background on the MIPS cost measures. So there are currently 5 episode-based cost measures in development. The measure development contractor Acumen uses a process based on cycles or waves for developing a measure, a number of measures at the same time. The current wave of development is the 5th set of episode-based measures and covers a range of clinical areas, settings, and conditions that reflect agency priorities and measurement needs in MIPS. The first 2 measures are chronic kidney disease, or CKD, and end-stage renal disease, or ESRD. These have been initially developed several years ago for use in the Kidney Care First option of the Kidney Care Choices model, and are now in the process of being respecified for potential use in MIPS. The next 3 measures listed here, kidney transplant management, prostate cancer, and rheumatoid arthritis, began development last year in Wave 5. And all 5 measures assess the outpatient treatment and management for specific conditions, often over a long period of time. And they are now fully drafted and undergoing field testing. And I just want to stress that these measures are still in development and testing stage, and they are not currently in MIPS, and they do not have any impact on MIPS scores. And after the development process wraps up later this year, CMS may consider these measures for future use in MIPS as part of the cost performance category. Next slide, please. So field testing is an opportunity for any interested parties to learn about and provide feedback on the draft measure specs, specifications of episode-based cost measures currently under development. Field testing is currently taking place over 4 weeks from January 17th until February 14th of 2023. Field testing is one of the steps in the cost measure development process, so this is the 5th time that we've conducted a national field testing period. During this time, clinicians and clinician groups will be able to access field test reports on the Quality Payment Program website, which describe their performance on the measures as currently specified, if they have at least 20 episodes of any of the measures. All interested parties will be able to review draft measure specifications and testing results on the MACRA feedback page. And any individual or organization can submit feedback via an online survey about any aspect of the draft measures. There are separate surveys about the specifications and then the lived experience with any of the clinical topic areas being measured. These surveys provide a jumping off point for feedback, but stakeholders can provide comments on any aspects of the measures. And finally, all the feedback that we receive will be considered in the next step of wrapping up measure development. Next slide, please. Now for just some context on the merit-based incentive payment system, or MIPS program, where these measures could be used in the future. So the Quality Payment Program has 2 tracks for clinicians to choose from: the Advanced Alternative Payment Models and MIPS. Clinicians who participate in MIPS have their performance assessed across 4 categories: quality, cost, interoperability, and improvement activities. A clinician's performance score for each category is rolled up to a MIPS final score, which then determines a payment adjustment. Each of the MIPS performance categories has a weight assigned to it. The weight of the MIPS cost performance category has increased incrementally over time. 2017 was the first year of MIPS, and the cost performance category was weighted at 0%. Each year since then, it has increased by 5 or 10% to provide clinicians with adequate time to prepare and gain experience with the cost measures while they represent a smaller portion of the MIPS score. In 2020 and in 2021, the cost performance category was set weight at 15% and 20% respectively, but they were reweighted to 0% and redistributed to other performance categories due to the impact of COVID-19. And in 2022, the cost performance category was set at 30% of the MIPS final score, which is required by statute. And for 2023, the cost and quality performance categories are now equally weighted at 30% each. Next slide, please. So within MIPS, there are different participation options. Traditional MIPS continues to be an option, but there is also a new participation framework called MIPS Value Pathways, or MVPs, available from 2023. MVPs are a way to collect quality, cost, and improvement activities categories while maintaining the promoting interoperability category and population health measures in the foundational layer across all MVPs. The goal of the MVPs is to simplify participation in MIPS and to provide clinicians with a set of aligned measures across performance categories that are meaningful to their care practice. 7 MVPs will be available starting in 2023. And MVPs are required to include at least one cost measure. This ensures that the value of care, or in other words, the health outcomes for a given cost, can be assessed. If the measures currently being field tested were to be used in MIPS sometime in the future, they could also be included in MVPs to enhance the way that it assesses value or allow new MVPs to be created. Next slide, please. The cost performance category is calculated as an average of all cost measures that apply to a given clinician or clinician group. For both traditional MIPS and MVPs, the cost measures are automatically calculated using administrative claims data, so there is no additional reporting required for clinicians. And the difference is that clinicians participating through an MVP will only be scored on the cost measures that are 1, in that MVP, and 2, where they meet the case minimum based on claims data. Cost measures represent the cost of Medicare for the items and services furnished to a patient during an episode. Currently, there are 2 general types of measures in the cost category. The first are global, or population-based measures, which focus on broad types of care. Specifically, these usually focus on clinicians who provide primary care services or who provide care in an inpatient hospital setting. And the second type of cost measures are episode-based cost measures, which focus on clinicians who perform specific procedures and provide care to treat or manage particular conditions or other defined types of care. And the next slide, please. And the MIPS cost performance category started with only 2 cost measures in the first year of MIPS. Since then, we have gradually added measures, including 23 episode-based cost measures and completing comprehensive reevaluations for the 2 population-based measures. There are now a total of 25 cost measures in 2023. Next slide, please. And now I'm going to turn it over to Joyce Lamb from Acumen, the measure development contractor. Thank you.
Thanks, Ray. Hi, everyone. I'm Joyce Lamb. I'm the project manager from Acumen for the cost measure development project. So I'll start by providing a brief overview of the cost measure development process before diving into the details of measure construction and the specifics of the measures being field tested. Next slide, please. Our measure development process involves gathering extensive input from a wide range of interested parties to make sure that the measures are clinically valid and can meaningfully assess the clinician's costs of care. As Ray mentioned, we've been developing episode-based cost measures in cycles or waves where development activities take place on the same timeline. We convene expert panels called Clinician Expert Workgroups, or workgroups for short, based around particular clinical topics. We've been convening these panels since 2017, and we're now in wave 5 of development, which began last year. This involves the input and expertise from over 45 members across 36 specialty societies and organizations. Across all 5 waves, we've worked with hundreds of members affiliated with many societies, professional organizations, and other associations. Next slide, please. Throughout Wave 5, we've sought a range of input to support measure development through different mechanisms, each of which serves a distinct role. We have a standing technical expert panel, or TEP, which includes members from a range of clinical, academic, practice management, and patient and caregiver perspectives. This TEP provides high-level guidance for topics across the project, and specifically for the measures in Wave 5, the TEP had provided input over the past years on the measure construction framework for how to assess costs for chronic conditions and which clinical topics to prioritize for development, given current gaps and needs in the program. We've convened 3 work groups composed of around 15 members each who have experience and expertise in the area of care being measured. These work groups provide detailed input to build out every aspect of the specifications across a series of meetings throughout development. At the same time, we've sought input from person and family partners, or PFPs, that is, individuals with lived experience relevant to each measure. PFPs shared feedback through focus groups and interviews, with 1 to 2 PFPs also joining workgroup meetings to discuss the findings from a broader set of folks who participate in focus groups or interviews. And these findings cover different aspects of their care experience, like which clinicians they see as being part of their care team and highlighting ways that their own care experience could have been improved. In addition to these panels and PFP input, we've gathered feedback at the beginning of Wave 5 with a public comment period. During this time, organizations and individuals provided feedback on candidate measure concepts, approaches to address clinical and coding challenges, and the expertise necessary for a smaller panel to build out the measure. With this feedback, combined with empirical analyses and environmental scans, we worked with CMS to confirm the final 3 measures that we're developing in Wave 5, in addition to the CKD and ESRD measures that we were working to respecify to MIPS. The public will again have an opportunity to comment on the draft measure specifications during this field testing period. Next slide, please. Here, this slide shows a timeline of each stage of development activities for the kidney transplant management, prostate cancer, and rheumatoid arthritis measures. The whole process spans about 18 months, starting with the public comment period for prioritization back in February 2022. Since then, the work groups met twice in July and September to discuss the measure scope, service assignment, exclusions, and risk adjustment. After field testing, we'll share all the feedback that we receive about the draft measure specifications with the work groups for them to consider as part of finalizing the measure specifications. So that covers the process for those 3 measures. As we mentioned, there's also the 2 kidney measures for CKD and ESRD. We actually began respecifying these for MIPS back in 2021, but their timeline for development was extended to allow for them to be field tested at the same time as the kidney transplant management measure. So together, all these 3 measures form a suite of kidney care cost measures. Next slide, please. Across all 5 measures being field tested and all of our development activities, we're guided by principles that have been defined and vetted by the TEP and other stakeholders over the past years. These principles are intended to hone in on the specific aspects of a measure to make sure that it's effective in assessing clinicians' cost performance. This slide includes a list of criteria that we keep in mind when developing measures. Clinicians should be able to review and readily understand measure specifications and be able to anticipate when an episode will be attributed to them. Since the measures capture costs related to various aspects of clinical care, whether episode-based or population-based, it's important that the measure specifications have clinical face validity and are consistent with practice standards. The measures should include costs of care that relate to the clinician's role for the particular measure focus. This is important so that the measure can be used to convey information that clinicians can then use to influence costs and improve their performance on the measure. Sometimes a set of services in a measure could be broad to reflect a broader clinician role, for example, a measure that focuses on primary care, while other times it could be more specific for a defined procedure like cataract removal. One related consideration is that the measure should include services so that the measure has sufficient variation so that it can distinguish between good and poor performance. Lastly, on a practical note, measure specifications must allow for consistent calculation and reproducibility using Medicare data. By having a general framework for cost measurement, it helps ensure that the measures follow these principles while also being flexible enough to create measures for the care of each condition, procedure, and setting being assessed. Next slide, please. So I'll now walk through the construction steps for the measures. Next slide, please. These measures being field tested all share a similar construction methodology, as they're all focused on capturing the role of clinicians providing outpatient management of the specific condition. This slide lists out the steps of measure construction, and we'll go through each of these in the following slides. Next slide, please. First, we identify the patient cohort by looking for a combination of services and diagnoses that indicate that there is a clinician-patient relationship focused on a particular type of care. We do this by looking for a pair of services billed by the same clinician group, or TIN, within 180 days of each other. These services represent care for the specific condition. They include evaluation and management, or E&M services, and also condition-specific services that we come up with through the input process with our work groups. For instance, for the kidney transplant management measure, it includes kidney education services. These services can be paired with diagnosis codes to make sure that we're capturing the care relationship that we intend to. Next slide, please. Since chronic conditions are by their nature ongoing, we identify the total length of this clinician-patient relationship by looking for additional services that indicate a continuing relationship. So the trigger event, the combination of those two services, opens an attribution window, and this can be extended if we see a claim that reaffirms continuing care. For these measures, that attribution window is 365 days. If there are multiple reaffirming claims, as shown here, each will have the effect of extending the total attribution window. Next slide, please. We define an episode as a set period of time during which costs will be assessed and then attributed in the study period in which it ends. It's constructed by taking the whole attribution window and then dividing it up into episodes. So each episode forms a unit that allows us to examine costs and compare clinician performance. For greater granularity, episodes can be stratified into a set of mutually exclusive, exhaustive patient cohorts called subgroups. This stratification allows the measure to focus on more homogeneous clinical groups within the overall patient cohort. This technique is something that we use in cost measures for more meaningful comparisons. So for instance, the diabetes chronic condition measure, which was added to MIPS in 2022, uses subgroups for type 1 and type 2 diabetes. Next slide, please. The fourth step is attribution. It's tightly linked to the triggering confirming services because it's those services that allow clinicians to know when they could be held accountable for care. Since MIPS has participation options at the group and individual level, the measure has attribution rules for both forms of participation. Clinicians overwhelmingly have been participating in MIPS as groups, so the TIN level cost measures are the ones that are mostly used. And for the TIN level measure, we attribute the episode to the TIN or the clinician group that provided the initial set of services, trigger services that indicate the start of a clinician-patient relationship. Next slide, please. For clinicians who participate as individuals, there is also a TIN-NPI level measure. Within a TIN that's attributed the measure, an episode can be attributed to any TIN-NPI that billed 30% of the triggering confirming claims to ensure that we're identifying clinicians who have been involved in the patient's care. In this diagram, we demonstrate how certain clinicians within the TIN are attributed an episode, while others are not, based on the share of services that they billed. There's additional checks to make sure that the TIN-NPI attribution is identifying the role of the individual clinician, such as making sure that they saw the patient within a year of the episode start. Next slide, please. So now that we've defined the patient cohort, identified the responsible attributed clinicians, and the period of time when care is being assessed, we can look at the specific services that are included in the measure. Only the services that are clinically related to the care are included. That means we gather a lot of expert and patient and family caregiver input to help identify which services are those for which the clinician can reasonably influence the occurrence, intensity, or frequency of them. In this example, for kidney transplant management, the diagram shows the services that a patient receives over time. Above the line are services from the attributed TIN, and below the line are services from other providers. The services in black are included in the measure and reflect care for kidney transplant management, such as E&Ms, kidney education, anti-rejection medication, and complications like fluid overload. The grayed out icons are the services that the patient receives, but which are not clinically related to kidney transplant management. So those costs aren't included in the measure. In this example, you can see there are some grayed out icons for imaging and physical therapy for low back pain and an eye exam. We use standardized Part A and B costs, which remove variation in payment that's not due to clinician care choices, such as geographic differences in labor and adjustments made under Medicare programs, like for graduate medical education. Measures also consider whether to include Part D costs, and this is something considered on a case-by-case basis. The guidance that we've heard from our TEP is that Part D can be included where it makes up a large share of costs and where including these services is necessary to fully understand the clinician's performance. For all of the measures being field tested, they do include Part D costs. Like with Part A and B, these are standardized costs. Since not all patients have Part D coverage, the measures further stratify or subgroup episodes by Part D enrollment. This means that episodes for patients with Part D are only compared with other episodes with Part D. We calculate the standardized observed cost as a scaled figure, since episodes can be different lengths depending on whether we see evidence of a continuing care relationship. Next slide, please. Next, we apply exclusions to remove certain episodes from measure calculation. These exclusions ensure that we have complete data for each episode and remove episodes that are so different that they can't be adequately accounted for through other techniques. We calculate the expected cost for episodes by applying a risk adjustment model separately for each subgroup, if applicable. This model adjusts for factors outside the clinician's control that can affect the cost of care, such as pre-existing health conditions. Risk adjustment ensures that providers aren't penalized for treating more complex patients. Next slide. Finally, we take the observed over expected, or O over E, of each episode, and then we average that across all episodes attributed to the clinician to generate the measure score. This is a weighted average to take into account longer episodes. We then multiply this weighted average episode cost ratio by the national average observed episode cost to generate a dollar figure. Next slide, please. So now that we've covered the framework for measure construction, I'll talk through the specific measures being field tested. Next slide, please. So to start with the kidney care measures, there's the CKD, ESRD, and kidney transplant measurement, or KTM. All three measures aim to capture aspects of kidney care as a priority area because it's both costly and affects a large number of patients. As mentioned, the CKD and ESRD measures are being respecified for MIPS after their initial development for an APM. During this process of respecification, we had convened an expert panel who expressed strongly that there was a need to include kidney transplant recipients in a cost measure because this is a really important patient cohort that shouldn't be left out of a measure, and that improved management of kidney transplant would reduce transplant failures that result in costly return to dialysis. So that's the gap that the kidney transplant management measure addresses. Next slide, please. These three measures work together to assess the whole chronic kidney care continuum. The CKD measure evaluates costs for managing and treating stage 4 or 5 of the disease. Clinically related services included in the measure include office visits, labs, imaging, Part D medications, renal-related ED visits, management of complications, and other surgical services for infections. If a patient progresses to having ESRD, the CKD episode will end. If there are services indicating care for ESRD, then an ESRD episode can start. A trigger event for the ESRD measure can be an outpatient E&M service, dialysis education, or monthly capitation payments. Clinically related services are generally similar to those included in CKD in that they include the costs of ongoing kidney care, exacerbations, complications, and also includes the cost of dialysis. If a patient receives a kidney transplant, this will end the ESRD episode as the patient no longer has ESRD. A KTM episode can begin if there are services indicating care for the transplant management. We only start looking at services at least 90 days after the transplant surgery. This is to ensure that the measure captures transplant management rather than surgery recovery. The KTM episode also includes similar services, plus transplant-specific services such as anti-rejection medicine. The KTM episode will end if a patient experiences transplant failure, since there's no longer any transplant management. If the patient then has ESRD, an ESRD episode could begin. Next slide, please. Next, we have the prostate cancer measure, which is the first episode-based cost measure that focuses on cancer care. The measure concept is broad, which includes patients who have low-grade prostate cancer, as well as patients with more severe forms of prostate cancer. This broad focus is intended to be inclusive and to increase the potential for the measure to be impactful, since there are no cost measures focused on cancer care in MIPS yet. One of the key aspects of the measure that we've been working on is making sure to account for cancer severity, since that would affect the expected costs. This involves some challenges because ICD-10 diagnosis codes don't have this level of specificity. In fact, there's just the one diagnosis code for prostate cancer. So to account for this, we've divided beneficiaries into two subgroups, patients with and without metastatic cancer. We determine this categorization by identifying patients with malignant neoplasms or recent use of metastatic cancer drugs. As shown in this table, the majority of patients in this measure have not had metastatic cancer. The risk adjustment model is run separately within each subgroup, so patients with metastatic cancer only compared with other patients with metastatic cancer. Next slide, please. This slide shows the specialties who are attributed using the attribution methodology described earlier, where we look for services indicating a particular care relationship. These include urology, radiation oncology, hematology oncology, internal medicine, and medical oncology. This also shows how the input from patients and caregivers is used to confirm empirical testing, as these specialties were all identified by our PFPs as being part of their prostate cancer care team. Next slide, please. Finally, we have the rheumatoid arthritis measure. This is a measure that also helps to fill in gaps because there currently aren't any episode-based cost measures in MIPS for rheumatologists. As shown in this table, rheumatologists make up the majority of attributed clinicians for this measure, alongside smaller numbers from other specialties, reflecting the role of primary care clinicians in managing rheumatoid arthritis. Some of the themes that we've heard from patients and others with lived experience is about their experience and the importance of timely and appropriate management of rheumatoid arthritis. Some examples that we've heard include that individuals felt that improvements in care could have prevented serious complications such as joint replacements and loss of mobility. This measure includes the cost of Part B and Part D drugs for the management of rheumatoid arthritis, as well as other treatment like physical and occupational therapy. It also includes mental and behavioral health services, as the input that we've received from our work group and from PFPs highlighted the importance of this kind of supportive care in managing this condition. So I'll now hand over to my colleague, Liz Peters, to walk through field testing materials.
Thanks, Joyce. We'll now talk more about how to participate in field testing overall. Next slide, please. The purpose of field testing is for all interested parties to share their input on these draft measures while they're still in development. As such, we provide stakeholders with a wide range of materials to inform their feedback. Eligible clinicians and clinician groups can access field test reports to see how they would perform under a measure, and anyone can review measure specifications, testing results, and additional general resources. We'll consider any feedback and share this with the work groups when discussing ways to further refine the measures. The following slides provide more details on the materials available for review. Next slide, please. So field test reports are available for download on the QPP website for clinicians and clinician groups who have been attributed at least 20 episodes for one of the measures. A total number of around 7,000 clinician groups and a little over 13,000 clinicians will receive at least one field test report during this period. There is a separate field test report for each measure that you have a minimum number of episodes for, so you may receive more than one measure-specific report. If you need guidance on how to access the field test report, there is a user access guide available on the MACRA feedback page. There's also a mock report available for folks who do not receive a field test report but are curious about what their format is and what information is included. Next slide, please. In addition, we've posted draft measure specifications on the MACRA feedback page. This includes measure methodology, which explains the measure construction, and the codes list, which details the medical codes used to construct each element of the measure. Elements include triggers, subgroups, attributable specialties, assigned services, risk adjusters, and exclusions. We also have a document that lists a set of questions for each measure intended to provide a starting point for reviewing when you're thinking about the specifications. However, you can provide feedback on any aspect of the measures. Next slide, please. There is supplemental documentation that you can review as well. These include testing results, such as descriptive statistics about the measure scores, breakdowns by provider characteristics, services that are driving costs, and an examination of the episodes that are excluded. In addition, there's a summary of the measure development process for Wave 5 and an overall FAQ document with some additional information. Next slide, please. You can provide feedback on the draft measure specifications of the 5 measures from January 17th to February 14th, as we mentioned, through the online survey listed here. When submitting feedback through the survey, you can also attach a PDF or Word document if you would prefer to submit a comment letter instead of providing responses to each survey question. And comments can be submitted anonymously if preferred. Next slide, please. Now that we've discussed the field testing process, we'll provide more detail on the information that's available in the field test reports and walk through an example of a kidney transplant management report. So I will begin the walkthrough now. Next slide, please. The field test reports are intended to provide information about how you would have performed on a measure as currently specified. It has 3 components: a PDF report containing a summary of your score and different breakdowns of what costs are included in the measure. An accompanying CSV file provides episode level details for attributed clinicians and groups interested in more granular data. And then a data dictionary in the format of an Excel workbook explains each of the metrics that are in the episode level file. Next slide, please. There are 4 different sections in the PDF report, including your measure score breakdown of the cost measure performance, episode cost statistics, and where to look for additional information. And then the CSV episode level data file includes identifying episode and patient information, as well as sources of episode costs. Next slide, please. We'll now take a few minutes to demonstrate navigating through your field test report and supplemental materials by providing a walkthrough of the kidney transplant management field test report. So I will start by pulling up some resources. Okay, so first we're going to pull up the PDF report, which is where most clinicians who receive a report will begin when participating in field testing. You can do this by navigating to the QPP website and logging in here. So this is where you would sign in. If you're unsure how to access your report, we recommend navigating to the MACRA feedback page and pulling up the user access guide for detailed steps. This is the MACRA feedback page, and here is the, the field testing materials that are all available, and here's the user access guide, which has some additional information. When you download your report, you'll see a zip file for each measure that you received a report for. Today, we're going to be looking at the TIN report, so like this. And once you open up your report, you'll see the 3 different components available within it. So here is the mock kidney transplant management field test report. Section 1, measure score, first provides a high-level summary of the kidney transplant management cost measure. Table 1, right, which you can see here. Table 1 then shows the cost of services you provided and how you compare with other TINs. Specifically, it shows you your measure score, which represents the average risk-adjusted cost of Medicare across all of your kidney transplant management episodes. And here, a lower score is better. You can compare your score to the national average and to your TIN score percentile, which indicates the percentile of your performance among all TINs nationally. So for example, if your cost measure score percentile is in the 40th percentile, then that means that your cost measure score was higher than the scores for 40% of TINs nationally, and lower than the scores for 60% of all TINs. You can use this to get a baseline of your resource use compared to your peers. There's also a full national distribution of all TIN measure scores that met the 20 episode volume threshold for your reference depicted here. Section 2 is the breakdown of cost measures performance, provides information on the different ways of characterizing what types of costs are included in the measure and a comparison of your performance to other clinicians. So the Medicare setting and service category table provides a breakdown of service use and cost, as you can see here, using Vados categorizations. And as you can see in the far column, these categorizations show you how often your episodes have particular services and allows you to compare this to the national average and to TINs within your risk score bracket with a similar case mix and complexity. You can also see the service use and cost by clinical theme, which provides similar metrics for comparison, broken down by clinical themes, which are basically mutually exclusive groups that represent clinically related services. And these themes can help you further contextualize where these costs are coming from across your episodes. And finally, we have a table that shows the clinicians who contributed the most Part B physician supplier costs to your episodes, both inside your TIN and outside your TIN. And this can show you which other clinicians are most involved in the care of your patients. So section 3, episode costs, provides the distribution of your episode costs. Table 4 is intended to indicate on average how expensive your episodes are expected to be relative to other TINs episodes, as predicted through the risk adjustment model. Your distribution can be compared to a figure that illustrates the national distribution of risk-adjusted episode costs for all episodes among clinicians with at least 20 episodes. And again, a lower percentile here indicates that your episodes are on average expected to be among less costly episodes across all TINs. So next you can pull up the episode level CSV file and the accompanying data dictionary. So the CSV file, I'll show a blank version of what that looks like now. The CSV file provides more granular information for each episode, including identifying beneficiary and care providers, and a breakdown of costs for each episode by setting. The data dictionary provides a definition of each metric used. And by metric, we mean these fields that are up here. So when you pull up your CSV file, obviously all of these fields will be filled in with data. And to make sure that you're understanding each of these fields, we recommend pulling up the data dictionary as well, which I will pull up so you can see. So here's the data dictionary for the CSV file, and here you can see the variable names and a description of each of them. So this is intended to provide context to where your costs are coming from and which episodes might present opportunities for improvement or trends you might want to be aware of as a practicing clinician. To help you providing feedback on a particular measure, you can review the methodology documents and the measure-specific field testing questions. And all of those documents are available on the MACRA feedback page, which we initially pulled up here. A helpful resource in particular is the quick reference specifications in section 3 of the measure information documents. It gives you an overview of each of the measure components, like what codes are trigger an episode, what services are included, or what measure-specific risk adjustment variables are used. And the rest of the document helps to provide context on how the measure is calculated. So just for an example, this is what the quick reference looks like. And if you're looking for more granular information on what is specifically included in the measure, you can review the codes list information, where you can see each code that's included in the measure. And finally, the measure-specific field testing questions are helpful to have on hand as you're reviewing the measure specification materials in your report, because it will guide you on elements to pay attention to or places that we might be looking for feedback on in particular. Again, though, you can provide feedback on any element of the measure or field testing in general. And once you're ready to provide that feedback, you can pull up the field testing feedback surveys that we've linked and that are also available on the MACRA feedback page, and either provide responses through the survey or skip to the end and attach a comment letter. This concludes the walkthrough, so we can return to the slides now.
Okay. We are now going to start the Q&A portion of today's webinar, and you can ask questions via the Q&A box or through webinar audio. So just a quick reminder, to ask questions via the audio, please raise your hand and we'll unmute your line so that you can speak. Or if you'd like to ask a question anonymously through the Q&A box, please click send anonymously. Otherwise, all attendees will be able to see your question. So it doesn't look like we have questions right now, so we will give it just a moment. If you do have pending questions, you can go ahead and submit them through the Q&A box or raise your hand and we will unmute your line. Just another reminder, if you do want to ask a question live, please go ahead and click that raise hand button and we will unmute your line, or otherwise you can submit questions through the Q&A box. And it looks like we have our first question. It says, can we receive credit for any MIPS category by participating?
Thanks for the question. So this is still in development, these field testing periods. So there's no impact on any MIPS scores at this time. So no, the answer is no, there won't be any credit for any MIPS categories by participating in field testing. But we do really encourage you to use this opportunity to give us feedback about the measures while they're still in this development phase. Thanks.
Great. And the next question says, I have access to QPP, but don't have the right level of access to get the report. How do I fix this? And just to read the question again, it says, I have access to QPP, but don't have the right level of access to get the report. How do I fix this?
Thanks for that question. For any issues accessing your reports, you can reach out to the QPP Service Center via email or telephone. Typically, if you're having trouble accessing the report, if it's a TIN report, we would recommend reaching out to the administrator for your clinician group. Typically, they have information on who is able to access it, but we think that generally the first line of defense is to reach out to the QPP Service Center or help desk via email.
Great. And we'll give it another minute or so for folks to submit questions. Again, you can raise your hand and you'll be able to ask a question live that way as well. One more question for CKD or KTPs, are these for patients that are being referred to out for transplant or for patients that an oncologist would treat for CKD for both for cost?
Hi, so this is Heather. I'm going to try to answer this question. If we don't provide enough clarification, I'll just ask the attendee to ask a clarifying question, but essentially, the cost measures really look, they are attributed to providers who have an ongoing relationship of care for these patients. So for an example, for kidney transplant patients, there are trigger codes and trigger diagnosis codes and treatment codes that we use to identify a clinician who has an ongoing relationship with these patients. So essentially, we'd be looking for a provider, physician who would be treating this patient and billing these codes to establish that relationship. The same thing is true of the chronic kidney disease. And if you have questions about which codes are included, I would refer you to the measure specification lists.
Great, thank you. We'll give it another minute for folks. If you do want to submit a question or raise your hand, please go ahead and do so. And we did just receive another question that says, could you please explain again why a cardiologist would be attributed episodes for prostate cancer?
Thanks. So this is really is based on what we see in the claims data for identifying that clinician-patient relationship. So if we see the trigger events, so trigger confirming services billed by the same TIN within 180 days of each other, that's when we identify the start of this. So it depends on what level of report you're receiving. So for instance, it might be that a cardiologist is part of a TIN who has billed these services, and that might be why they're seeing this report if you're participating as a TIN. At the TIN-NPI level, this might be because they have been seen to have been billing these trigger confirming services and met the volume threshold for the purposes of field testing. But from the testing that we've done, and I think we had one of the earlier slides which listed out the most frequently attributed specialties for prostate cancer, we don't see cardiology in that. So the top ones, just to read them out, urology, radiation oncology, hematology oncology, internal medicine, and medical oncology.
Great, and it doesn't look like we have any other questions at the moment, so we will give everyone another minute or so. If you'd like to submit a question or raise your hand, please go ahead and do so. And one more question, will the prostate cancer cost measure be applied to this performance year, to 2023?
No, the prostate cancer measure is currently being field tested, so it will take a little bit of time for it to go through the typical rulemaking cycle. And if it's put in the rule, then that would be applied to the, one of the future performance years. So not 2023.
Great, thank you. And one last final reminder, if you would like to submit a question, please go ahead and do so. We'll give it one more minute or so. Okay. Well, it doesn't look like we have any other open questions, so this concludes today's Q&A session. And Liz, I will turn it back to you to go through the remaining slides.
Thank you. So as we mentioned, field testing materials and resources will be available on the MACRA feedback page. Some other potentially helpful links are also listed here that you might need. Next slide, please. And finally, if you have any questions about the information that we reviewed today, please direct your questions to the QPP help desk, which can be found at the contact information listed here. And we'll be happy to address any questions through this format. And we look forward to receiving any feedback. As a reminder, it's due by February 14th. Thanks all for joining us, and we look forward to hearing from you.